Good afternoon, everyone. It's a pleasure to welcome you to the second plenary of the 48th Critical Care Congress, our late breaker sessions. Before we begin, a couple of housekeeping announcements. There will be no question or answer during this presentation. At the end of the session, I'm going to invite the speakers up front, so if you have questions to ask them, please feel free to come up after all three of the talks are concluded. Before we begin with the late breakers, I want to give you an introduction to our new journal, Critical Care Explorations. This is the third official journal of the Society of Critical Care Medicine. The most important thing is our website, ccejournal.org. It's an open access journal, which means the articles will be available online in perpetuity, free of charge to every reader. It's going to be fast with early decisions. The editor-in-chief, that's me, and a senior associate editor will look at every submission and give it a quick read. If we send it out for review, we're aiming for expedited review and publication within 35 business days of the original submission. We aim to be an affordable open access journal with lower costs than you've seen. And if you want more information about the journal, let me invite you to go to the website and see the foreword, Exploring the Endless Frontier. There you'll find more details about the new publication. Well, now let's go on to what you've been waiting for, and that is our late-breaking articles. The first study, Sepsis Surveillance Using Adult Sepsis Events Simplified eSOFA Criteria versus the Sepsis 3 SOFA criteria, will be presented by Dr. Chanu Rhee. This study is being simultaneously released in the Society Journal, Critical Care Medicine. Dr. Rhee.
Good afternoon, everyone, and thank you to Tim and the organizers for the opportunity to present today. I will jump right in. I have no conflicts of interest to disclose. So all of us know that sepsis is the leading cause of death and disability. And growing recognition of the scope of the problem has catalyzed local and national initiatives, including Rory's regulations in New York State, the CMS SEP1 measure, and hospital quality improvement efforts around the country. As a result, there is now intense interest in tracking and benchmarking hospitals on their sepsis incidence, outcomes, and quality of care. Up until now, sepsis surveillance has primarily been done using administrative data, but these have important limitations. Medical record reviews have shown that they have low to moderate accuracy. There's variability across hospitals. And importantly, they're susceptible to changing diagnosis and coding practices over time as a result of factors such as rising sepsis awareness, better screening and detection, more diligent coding, and changing consensus definitions. All of these problems are compounded by inherent subjectivity in diagnosing sepsis. Several years ago, we used national administrative data to show that sepsis as a primary diagnosis tripled over an 8-year period. But when looking at the infections that most commonly lead to sepsis, like pneumonia, intra-abdominal infections, urinary tract infections, and bacteremia, they were all actually stable, or in the case of pneumonia, actually decreasing. As a result, over the past several years, my colleagues and I have been interested in tracking sepsis more objectively, in particular by leveraging the increasing national uptake of electronic health record systems to identify clinical indicators of sepsis, such as presumed infection as marked by cultures and antibiotics, and concurrent organ dysfunction by markers such as vasopressors, mechanical ventilation, and abnormal laboratory values. And pilot data from our local academic hospitals demonstrated that this was feasible and more accurate than administrative data. The Sepsis 3 Task Force also used EHR data to identify and test various criteria in patients with suspected infection, including SIRS, QSOFA, LODS, and SOFA. Ultimately, sepsis was operationalized as an infection leading to an increase in the SOFA score by 2 or more points, which was shown to be highly predictive of mortality in their analyses and many others. However, it's important to understand that there's no true gold standard for sepsis, and different criteria may be better suited to other purposes. In particular, the complementary arenas of real-time clinical care at the bedside versus retrospective surveillance for rigorous case counting. And while the SOFA score is well tested and useful for clinically characterizing septic patients at the bedside, there are important challenges when considering implementation of objective and consistent surveillance across hospitals. Here's a SOFA score, which defines organ dysfunction from 0 to 4 points across 6 domains. And when considering the respiratory dysfunction, arterial blood gases are not routinely measured. It can be difficult to distinguish arterial versus venous samples and identify the FiO2 at the time the blood gas is drawn. When considering cardiovascular dysfunction, spurious vital signs and transient escalations of vasopressor doses are common, and while that can be easily interpreted at the bedside, that can be problematic for electronic surveillance. The Glasgow Coma Scale can be subjective, not routinely measured, and also hard to assess in sedated patients. And lastly, for the renal dysfunction, the urine output is inconsistently measured and documented. Recognizing these challenges, several years ago, the CDC funded a consortium of researchers and public health officials with a goal to create a surveillance definition based on sepsis theory framework, but using objective and routinely available clinical data. As part of this effort, the SOFA score was adapted to facilitate consistent EHR-based surveillance, what we're calling now eSOFA. We also applied this definition to diverse hospitals to generate more credible estimates of the U.S. national sepsis burden. Here's the SOFA score again, and on the right is the adaptation to eSOFA. So the cardiovascular score was simplified into simply initiation yes, no, or vasopressors. Pulmonary dysfunction is initiation of mechanical ventilation. Renal dysfunction is doubling in creatinine or decrease of eGFR by 50% relative to baseline. Hepatic dysfunction is a bilirubin greater than 2 and a doubling from baseline. Coagulation dysfunction is a platelet count less than 100 and a greater than a 50% decline from baseline. And lastly, we did not use the neurological dysfunction because of the problems that I mentioned, and instead a lactate greater than 2 was chosen. The surveillance definition searches for a blood culture regardless of result, and within a plus or minus 2-day window around the blood culture looks for the start and continuation of antibiotics for 4 or more days, with fewer than 4 antibiotic days allowed if the patient dies, is discharged to hospice, or transferred to another hospital before 4 days. And this is called presumed serious infection. When paired with 1 or more eSOFA criteria, this is called a sepsis event. And as part of that project, we did more than 500 medical record reviews and showed that it had approximately 70% sensitivity and positive predictive value compared to sepsis 3 criteria. Although when considering clinically suspected sepsis as opposed to confirmed sepsis, the positive predictive value was nearly 90%. And this is more accurate than administrative data. And when we applied this to over 400 hospitals, administrative data showed a steady rise in incidence over a 5 to 6 year period, but when using EHR criteria, the incidence is relatively stable. And to us, the difference in these observed trends really underscore the need for implementing this type of surveillance on a more wide-scale basis. In March of 2018, the CDC released the Adult Sepsis Event Toolkit with a goal to help hospitals implement the surveillance definition so that they can more reliably track their sepsis rates and outcomes. However, there remain important gaps in knowledge. While we know that the adult sepsis event performed well compared to sepsis 3 on that sample of medical record reviews, there's otherwise no data on how sepsis patients detected using eSOFA compared to those that identified by the full SOFA score. And that was the objective of this study, to compare these 2 criteria using data from a large and diverse set of hospitals. Our hypothesis was that the simpler eSOFA criteria would identify similar types of patients as the full SOFA score with comparable predictive validity for mortality. And if this was true, that would support its use as a more practical surveillance method. We conducted a retrospective cohort study of adults admitted over a 3-year period to more than 100 U.S. hospitals in the Cerner HealthFacts data set, which contains the EHR data necessary to support both eSOFA and SOFA. It draws from a diverse set of academic and community hospitals that obviously use the Cerner EMR system. We identified patients with presumed serious infection based on the CDC criteria that I mentioned, with and without a concurrent increase in the baseline SOFA score by 2 or more points, sepsis 3, or 1 or more eSOFA criteria, adult sepsis event. This is a Venn diagram showing the overlap of the various criteria in our cohort of nearly 1 million patients. 11% of them met presumed infection criteria, 6% of them met SOFA sepsis theory criteria, and 4.4% met eSOFA CDC criteria, with an overlap of 3.6%, which indicated good agreement between the two criteria when measured by Cronbach's alpha of 0.81. This is a complicated table just showing not complicated, but it's a dense table showing the characteristics of sepsis patients identified by either method, and basically it distills down into the fact that the patients had similar demographics, a similar distribution of comorbidities, and a similar distribution of diagnosed infectious syndromes. When looking at their outcomes, the median hospital length of stay was similar between the two groups, but the eSOFA group was slightly more severely ill when considering ICU admission, 41% versus 35%, and in-hospital mortality, 17% versus 14%. When using SOFA score sepsis theory as a reference standard, the sensitivity of eSOFA was 60%, and the positive predictive value was 82%. That sensitivity may not sound so great, so we delved further into that and looked at the SOFA organ systems that were contributing to these eSOFA false negatives. And we found, not surprisingly, that it was really the neurologic score and the respiratory SOFA scores that were causing these so-called false negatives, because both of those can trigger 2 SOFA points without triggering one of the eSOFA criteria. Importantly, the sepsis 3 patients missed by the eSOFA had relatively lower mortality at 6%. We also looked at the fold change in mortality across baseline risk deciles as defined by age, sex, race, and comorbidities amongst patients with presumed infection. And not surprisingly, for patients that had a SOFA score increase of 2 or more, there was a substantial increase in the risk of mortality across all of these deciles. When looking at the eSOFA criteria, however, you can see that the risk of death, the increase of risk of death across deciles was actually fairly similar. And when looking at the overall predictive validity for mortality as measured by the area under the receiver operating curve, you can see that eSOFA was comparable, if not slightly better, at 0.77 compared to 0.76 for the SOFA score, statistically significant. Importantly, the relationship of eSOFA to SOFA in terms of prevalence, mortality, sensitivity, positive predictive value, and overlap was largely consistent across important patient subgroups as defined by age, comorbidity burden, and infectious diagnoses. The comparisons of predictive validity were also similar in an independent data set from 4 hospitals in the Emory system, and when using a broader definition of presumed infection based on the drawing of any clinical culture instead of blood cultures alone. So in summary, compared to the SOFA score in sepsis 3, the adult sepsis events eSOFA criteria identify a cohort with slightly lower prevalence and higher mortality, but have overall good overlap with low mortality amongst the missed sepsis 3 cases. They also identify patients with similar clinical characteristics with comparable, if not better, predictive validity for death. And since I would argue that eSOFA is simpler and uses more routinely available EHR data, the adult sepsis event could facilitate wide-scale automated surveillance that we can be confident tracks fairly closely with more complex SOFA sepsis 3 criteria. Furthermore, if widely adopted across the U.S. as recommended by the CDC, adult sepsis event surveillance could help clinicians, hospitals, and policymakers to more reliably track local and national sepsis incidents and outcomes, better interpret the impact of sepsis interventions, gain further insight into sepsis epidemiology and risk factors, and facilitate comparisons to peer institutions, all of which will hopefully help to drive further innovation and improvements in sepsis care and outcomes. With that, I will just briefly acknowledge all my co-investigators as well as funding from the CDC and AHRQ. Thank you for your attention.
Thank you, Dr. Rhee. Next, we'll hear from Professor Glenn Hernandez, who will present Andromeda shock, effect of a resuscitation strategy targeting peripheral perfusion status versus serum lactate levels on 28-day mortality among patients with septic shock. This study is being simultaneously released in the Journal of the American Medical Association. Dr. Hernandez.
Thank you. Good morning, good afternoon, ladies and gentlemen. Thank you very much for the organizer for inviting us for this very interesting session. The study is published online simultaneously in the JAMA journal, and the background is the following. We already know there is increasing awareness about the toxicity of resuscitation, especially the fluid overload, which, if inadequate, can lead in many septic shock resuscitated patients to prolonged mechanical ventilation, intra-abdominal hypertension, eventually increasing morbidity or mortality. But on the other hand, also the vasopressors and inodilators have a narrow therapeutic index, and if used inappropriately, they can also contribute to the toxicity of resuscitation. So we have to gain more insights in when to stop on how to do a more physiological resuscitation in septic shock patients. And this has been highlighted as a top research priority by the Committee of the Surviving Sepsis campaign recently. In fact, in terms of resuscitation, hemodynamic resuscitation, the best target or endpoint should be one that has a very straightforward relationship with increasing flow. If you increase flow, stroke volume, systemic flow, this variable should improve in parallel with this. It should be a real dynamic relationship between both. And see, this could be, at least theoretically, the best resuscitation target in terms of hemodynamic resuscitation. Lactate has been used for decades as a resuscitation target in septic shock, and nobody can argue about the strong prognostic value of lactate. And even it has been incorporated into the sepsis 3 definition, of course, and the sepsis surviving campaign guidelines recommend lactate normalization as an endpoint for resuscitation, and that it should be assessed every 2 to 4 hours because of the kinetics of recovery of this parameter. However, besides being not universally available, lactate, as you know, is a complex parameter. It is not specific of tissue hypoperfusion or hypoxia. It is influenced by the stress hyperadrenergia, of course, in many cases. And the kinetics of recovery of lactate is sometimes biphasic, erratic, and slow. This has been highlighted by several recent editorials and points of view, and in the study cited below, you can see that in a cohort of septic shock survivors, almost 50% of surviving patients had abnormal lactate values 24 hours after starting resuscitation. And if you try to normalize this lactate, you will probably lead to an increased risk of fluid overload or the toxicity of resuscitation. There are some parameters that are more closely related to your resuscitating maneuvers, such as peripheral perfusion, the venous arterial PCO2 gradient, or LCVO2. Lactate frequently behaves in a biphasic pattern with a rapid decrease at the beginning and then a slower one, probably due to the metabolic part of lactate. In contrast, peripheral perfusion is universally available in general, and it represents, under strict conditions, in sense, for example, of room temperature, adrenergic tone, the microcirculation of the skin, and you can see when you look at the skin during the resuscitation, during fluid challenges, for example, you can see the reperfusion in real time. You can see a cold evolving into a warm peripheral perfusion, probably represents reperfusion of the skin. And several recent studies have highlighted the strong prognostic value of having an abnormal versus normal peripheral perfusion after fluid resuscitation in the emergency department setting, also in the advanced ICU resuscitation, and in other settings. Almost a 25% of difference in mortality. So peripheral perfusion exhibits a fast kinetics of recovery. It changes in parallel with the improvement in more important or relevant physiological systems, such as the hepatosplanchnic perfusion, that has been demonstrated in a recent study evaluating the response of peripheral perfusion in parallel to the resistive indexes of several major hepatosplanchnic arteries, and they evolved in parallel. And in a pilot study, it was recently demonstrated that when you stop fluid resuscitation with normal peripheral perfusion as compared to classic hemodynamic variables, you give less fluids and you have a better evolution of organ dysfunction. So this is why we had interested in assessing the potential usefulness of peripheral perfusion as an endpoint of septic shock resuscitation. The objective was to compare a peripheral perfusion targeted resuscitation strategy against a lactate strategy in the impact to lower 28 days mortality. This was a prospective, multi-center, randomized controlled trial held designed by the Latin American Intensive Care Network, as I will show, that was performed in 28 ICU in 5 countries in Latin America. The outcomes are here. The main outcome was all-cause mortality at day 28. The secondary outcomes, including especially focus on organ dysfunctions, in the evolution of organ dysfunction, in the requirement of replacement therapies, and in the tertiary outcomes, we highlight here the amount of resuscitation fluid that you gave when you resuscitated against peripheral perfusion versus lactate. This is the flow of the protocol. The inclusion criteria was a septic shock according to sepsis 3, diagnosed less than 4 hours. You had to be less than 4 hours since the diagnosis to be included, to consider to be included in the protocol. There was a lot of exclusion criteria that are written in the JAMA paper. And after informed consent, the patients were randomized by a central system in 2 branches, in 2 arms. One, the goal during an 8-hour intervention period was to control lactate every 2 hours, as recommended by guidelines, and stop resuscitation if lactate had normalized or decreased more than 20% in this 2 hours period. In the other arm, capillary refill time that was used as a representative of peripheral perfusion was evaluated every 30 minutes according to its kinetics of recovery, and if when normal, it was assessed every 1 hour during the 8 hours intervention period. This is how we standardized the capillary refill time assessment. We put a slide glass from a microscope, and we compressed the ventral part of the index finger until it blanked. And then with the chronometer, we maintained this pressure for 10 seconds, and then we released, and then we counted with the chronometer the recovery of the skin perfusion. This procedure was standardized and practiced and trained in all the participating centers. This is the protocol. In this protocol, we just ordered recommendations of current guidelines for septic shock resuscitation in a stepwise fashion. The first phase was fluid resuscitation. We assessed fluid responsiveness as an obligatory step in all the patients, and the patients were fluid responsive. I will show the numbers later. In patients that were fluid responsive, we gave a bolus of 500 ml of crystalloids in general every 30 minutes, and we reevaluated the target. If the target was still abnormal, we reassessed the safety limits, CVP in this case, and the fluid responsive, and then we continued this cycle until it normalized or the patient became fluid unresponsive. If we did not normalize the target or got the goal with fluids, we went to the next step, which we named the vasopressor test, meaning that in patients that were chronically hypertensive, as recommended by the guidelines, we subjected these patients to a short period of 2 hours of an increase in mean arterial pressure to 80, 85, and looked at the goals. If we reached the goals, with this, we maintained this blood pressure. If not, we decreased the norepinephrine dose to the previous level to maintain just a baseline mean arterial pressure of 65. So this is why we put this as a test, just to avoid futile therapies in the patient. And the third step was, if this failed, or in patients that were not chronically hypertensive, we went to the inodalator test. We low dose dobutamine or milrinone according to the center for 2 hours, and then again we reassessed the goal, or we continued or stopped this therapy. Every participating center was asked in a pre-study survey if they had to evaluate fluid responsiveness as a routine practice. But we developed an algorithm to aid the centers for difficult cases, but we strongly recommended that they use the system that they were more familiar with, and this is the algorithm that was employed sometimes from the patients. The statistical analysis is described in detail in the sub-paper and in the JAMA paper today, but perhaps the most controversial part of this, until this moment, is the sample size calculation. This was a matter of a huge debate in the group, go to inferiority, go to superiority, etc. We had no previous data because this is the first randomized controlled trial assessing peripheral perfusion. So the only data that we had in the background to calculate the sample size was the result of some observational study, and discussing this a lot, finally we came up with this sample size. But because of the uncertainty, we developed this trial as an adaptive design, meaning that the Data Safety and Monitoring Board made a preliminary analysis, interim analysis in a blinded fashion with 75% of the sample with 300 patients. And if the mortality, this was pre-established, if the mortality fell in the promising zone in between 10 and 15%, they would have recommended to double the sample size. And we were happy to comply with that. But the mortality difference was 8% at that time, so they recommended to end up the study like it was. And when we look at the evolution of the difference in mortality, we'll speak later on, it was almost consistent between 8.1 and 8.5 at the end of the study, so no change was made. These were the 1,327 patients were assessed in the screening in the centers. This was a very intense screening. It required a lot of efforts with the emergency department where to capture the patients in less than 4 hours. I have to say at this point that this study had no funding except a logistic support from my university, the Catholic University of Chile. And finally, 424 patients were included. In baseline, the demographics were pretty similar in terms of severity, Apache, SOFA score, the sources, and the time from admission to the emergency department until they started the protocol. The hemodynamics in baseline, the norepinephrine dose, as you see, the CVP, the lactate levels, the CRT levels, etc., were similar, were equivalent between the two groups. This is quite interesting and will be subject or the matter of a separate communication later, because applying our algorithm, our intense commitment to assess fluid responsiveness, we could assess it in 82% of the patients, of the 424 patients, which is much higher than previously reported. And this is interesting also, 30% of the patients just admitted to the ICU before starting the protocol were fluid unresponsive. 1 in 3 just coming from the emergency department. And in fact, during the 8 hours of the intervention period, the fluid responsiveness decreased over time, and this is also in the supplemental material of the paper. The vasopressor test, meaning that we increased the dose of norepinephrine to 80-85 in chronic hypertensive patients that did not correct the hypoperfusion only with fluids. It was used more in the lactate group than in the peripheral perfusion group, and this was statistically significant, meaning that in the lactate group, there were more patients that did not resolve the hypoperfusion only with fluids. The success, however, was similar in terms of correcting the goal, achieving the goal. And the inodalator test was quite similar between the two groups. This is the main outcome, the lactate mortality, the peripheral perfusion mortality. It was, in terms of this, a negative study. We have to acknowledge this. It was close, of course, but it was negative, and in the difference in mortality was 8.5%, the absolute, and 20% relative difference in mortality in the 28 days mortality. However, when we looked at some secondary and exploratory outcomes, there were some signals. For example, the SOFA score at 72 hours was lower in the peripheral perfusion group. It's 5.6, 1 point lower. This was statistically significant, as well as the amount of resuscitation fluids that were administered during the 8 hours. It's a small amount, but statistically significant, 400 ml of fluid less than in the other group. There were some pre-specified subgroup analysis, and this is one, the SOFA score. We figured out that maybe eventually patients with less organ dysfunction at baseline would do better with the peripheral perfusion. And in fact, patients that started the resuscitation with SOFA score less than 10, they exhibited a mortality of 20 versus 39%, and this was statistically significant also. And this is a post-hoc analysis, just we wanted, it's only exploratory, of course, we wanted to look at the rate of improvement in organ dysfunction, and you see that it was faster also in the peripheral perfusion group. The study has, of course, many limitations. We acknowledge of the non-blinded design. We tried to fight against this with intensive training, auditing, reinforcements, and at the end, there were no difference in major violations or adherence or cross-treatments between groups. It was underpowered, of course. We tried to compensate this with an adaptive design. The inter-rater reliability was not assessed, but as you saw, we used a very standardized procedure. It could be considered a complex protocol in the sense that we used fluid responsiveness routinely, vasopressor tests, etc., of course. But if you think about it, are all therapies that are recommended by experts or the guidelines, and we just ordered them in a stepwise fashion. And at the end, it is an ICU-based study. It cannot be applied directly for primary medicine in resource-limited settings without training, of course. But we think that further studies should address this in the future. So, in conclusion, early septic shock resuscitation based on peripheral perfusion targeted strategy did not result in lower 28-day mortality. However, peripheral perfusion targeted resuscitation was associated with less treatment intensity in terms of resuscitation fluids and vasopressor testing. And because of the signals in at least 3 different parameters in the organ dysfunction area setting, we should probably, this signal should be probably explored, which is also consistent with the previous pilot study for further research. This study was not, this is my last words, was not designed as to be a mechanistic study. So, but we are now performing a mechanistic study, studying these 2 groups in fluid resuscitation, comparing the impact in surrogates of hypoxia, as lactate pyruvate and others, and also in microcirculation, etc. And I hope we have these results in the next year. Thank you very much.